So immuno-oncology is really picking up speed at a fast pace for lymphoma and other types of cancers and solid tumors. But I think the difference in lymphoma is that we have a subset of patients. These are the patients with Hodgkin lymphoma. They respond in an extremely impressive way compared to solid tumors. And then I'm talking about Hodgkin patients. So patients with relapsed Hodgkin lymphoma who failed frontline therapy and salvage therapy and autologous transplant and brentuximab vedotin and you name many other treatments, you give them simple naked antibody targeting PD-1, whether pembrolizumab or nivolumab, and you're getting about 70% response rate. You'd think that the immune system is beaten up by that time. It's amazing what to see that with a simple naked antibody inducing something. It's just remarkable. So we need to learn from Hodgkin lymphoma patients why these patients are having this high response rate, and would then the model be exported to other types of lymphomas and maybe also type of cancers. So that's important. So we're doing a lot of correlative studies, biopsies before and after, and sequencing and doing immunophenotyping so to figure out why patients with Hodgkin lymphoma do have this high response rate. But when we talk about immuno-oncology, I think there's immune therapy of lymphomas. It has multiple platforms. Checkpoint inhibitor is one of them, which is successful, and you can imagine now everybody's combining checkpoint inhibitors with a lot of other things, like solid tumor colleagues. But there's a CAR T cells now that, again, showing an impressive signal in patients with relapsed diffuse large B-cell lymphoma. The KITE, you can say, CAR T cell platform, probably is going to be the first drug that would be approved for patients with relapsed diffuse large B-cell lymphoma in the US. In Europe, there's Pixantron approved by EMA, not approved in the US. So that's also like a major news for us. And then you can again imagine what to do with this. Is it going to be like a single agent? Can we combine something with it? Should you give the CAR T cells followed by maintenance or adjuvanting? So this is the new area that is getting also a lot of attention. And thirdly, in between these two things, there's the bispecific platform, which is sort of like in between naked antibody and the CAR T cells. So like these are the antibodies with two heads, bring immune cells to the sites of disease. And there's now multiple platforms this is emerging, whether targeting CD19, CD3, or CD20, CD3, and others. That's still emerging, but I think it will pick up speed in the next couple of years. So it's a tremendous amount of work. Now, the second part of your question is about genetics, how we use genome sequencing to select patients. As of today, there's not a single genetic alteration that we can use to base therapy for lymphomas. There are trials based on the presence or absence of genetic alterations, P53, CREB-BP, EP300, EZH2, which recently got breakthrough designation by the FDA for relapsed follicular lymphoma, and IDH2, for example. But there's none of them has been approved yet as a selection biomarker. But that's area also of investigation. We and many other centers offering any patients with lymphoma who walk through the door that we will sequence their tumors for free to learn about the genetic fingerprints and then to match these kind of fingerprints with response or resistance to therapy.